Thank you very much. It's a big pleasure for me to be here, and it's a special honor to give Jørgen Bauer lecture. He has been a role model for me, actually, and he has been facilitating my career a lot, although I did not agree with him when I was a young researcher trying to publish in Acta Orthopedica. He cut 10 pages down to 1/2 or something like that. It was his brand. He didn't think we had to talk too much, just the news. But he was a great man, and I also remember his great talk in London in 1948 when he gave the history of orthopedics, you know, with all the icons from Aristoteles to the present time. So it's a big honor. Thank you. I am going to talk here, you know, with different hats. I have one hat as president of CICOT, the World Organization of Orthopedics, where we have more than 104 member countries. I'm also to talk as the president of the Nordic Orthopedic Societies, and I'm also to talk as a researcher at the University Hospital in Aarhus. I think this is a real great title to get, and I didn't get it myself. I was told to think about this. And of course, you know, being president of CICOT, you know, we have been thinking a little about what is actually our real roles. And the trauma burden is a major task. It is a real unbelievable, so great job it is in the dailyhood. It's a very nice job where we cure the patients, but we know sometimes with earthquake it's unbelievable the burden we face. We are very much aware about the aging population and the increasing number of patients we have to treat. I'll come back to that. We have to recruit good orthopedic surgeons, and it's quite demanding task. Orthopedics is not just orthopedics. It's a sub-specialized discipline where we even go to sub-specialization. We have to face the internationalism, and we have really to learn with all efforts. We have to combine and unify really to solve the various issues. Some parts of the world it's not so easy, and we think in CICOT it's a very important task to be outreach, really to reach those areas where they don't have educational programs. But then there is one thing which things must unify all of us. It is the lack of evidence-based treatments, which we really face also in orthopedics. And this is something I will come back to in my talk here. The aging population, I think most of you understand it's a global burden, and in orthopedics we can see it as a challenge because we really have now to provide the evidence of what we are doing in order to compete for the resources which will be less and less for our healthcare in the future. If we look back in what has been achieved, I think it is interesting to look at the dynamics on industrial development within orthopedics, and you can see that we have had a lot of ideas all the time. This is the curve of the Ortho 510K. This is a concept where you actually develop a product which is equal to the existing product, and it's rising very high. Even compared to cardiovascular surgery, you know, we are quite innovative in orthopedics, or the industry around orthopedics is very innovative. If we look at the pre-market approvals which we have seen in the past, there are some great things happening. This Infuse BMP is really a pioneering work of Marshall Urist, which has come to one of the biggest successes in the world of orthopedic industry, making this as a commercial product now by one company who is actually earning a lot of money on this. Also, we had the introduction of the disc prosthesis in the spine, which has been a controversial but certainly also a financially very important issue, and there have been a number of other absolute new products like vertebroplasty, like kyphoplasty, coming from absolute almost zero to a very high market. We can also see that orthopedics has become subspecialized when you look at the components related to the subspecialties. You can see there is a real growth in spine, in trauma, in the last decade, whereas hip and knees have been fairly constant, and I might address that later. The problem, you know, being orthopedic surgeon, that we must actually know what is the best treatment for the patient. That's the reason why case discussions in orthopedics is always one of the very best, because we have all the opportunities. We have to think everything in for the single patient. But of course, we must also know what is the real best, you know, if we were equally good in making any procedure. So I say, what is the best treatment? I think it's very difficult. We have to balance between consensus-based medicine and evidence-based medicine. And when we look at the evidence-based, I actually did a search on randomized controlled trials within various disciplines, you know, and you can see orthopedics are really not that good. Cardiovascular surgeons are much better within the same time frame to really produce hardcore scientific data. If we look into the subspecialties of orthopedics, we are doing a little better, but only up to 1/3 of the cardiovascular surgeons. So I think this is a way of thinking when you introduce new things, which actually we have to adapt to. I think we can do better. As a scientific society and as a group like this, I think it's very important to think who are the key players in the development. Is probably the industry in many ways. It could be surgeons, it could be patients' needs, it could be in the future healthcare providers. So I think we must be aware of this scenario. We must really make a happy marriage and a valid discussion between those actors to get into a better future. And I think as a scientific society, I think it's mandatory that we focus on what is really best. We must be able to tell the healthcare providers what is the best treatment. And that's the reason why I have instituted evidence-based medicine as a main component of any scientific event in CICOT. And I hope that will help for the future. But we must also be ready for the evidence of equivalence. You know, that this is regrettable. It's very regrettable for some people who think they earn their money on evidence-based procedures. And I know the big discussion we had, the New England Journal of Medicine paper on arthroscopic treatment, which didn't have any influence at all on their patients. It was big discussion. Also, spinal fusion and vertebroplasty has been a matter of debate, and it's very interesting to see these debates when they come. But a lot of improvement has taken place. We know the total joint arthroplasty by John Charnley has been very successful, and even last week we heard Ian Lermont conclude that we don't need more implants. We need better teaching of how to make those implants function, which exist. But anyway, there are many people who try to improve all the time, and we must be aware that it's a long path, and we have to go through various steps as depicted here by Henrik Malkau. We have to have these randomized prospective studies, multi-center studies, register studies in the various phases. But then we know the truth, but there's still a gap until we make the surgeons do the same as we conclude for the register studies. This is a real problem, so this is maybe one element also for a society like this really to discuss. But sometimes you can be very lucky. Although this was a retrospective lock with bone lock cement, it was a new brand new, good cement. All the nurses loved it, but it didn't work. And unfortunately, more than 50,000 patients got it in. But actually, in Gothenburg, with only 30 patients in the randomized prospective study, they were able to get the answer within 12 months. So if they had done this from the beginning, we would have avoided that disaster. Also, register studies which are improved can actually give some real truths, like how to deal with a displaced femoral head fracture. Really, these register studies show that you have to put in a hemiarthroplasty. Irrespective of this, people are not obeying, and you can see that, for instance, with the variation in use of hip prosthesis in Scandinavian countries. In spine, also evidence-based medicine has been questionable in many areas. This is what we did in the 70s, and this is what we do today. Previous 1 year for having a spine straightened, now 1 week and you are home. Previous 1 year. Now even we can operate on small children with crippled spine with telescoping growing rods and achieve much better result and better survival of the patients. But now we move into another area also. It's not just about putting in implants, making spine straight. We also focus a lot on a lot of new initiatives in regenerative medicine. For instance, how to fix such a degenerated disc, with a protrusion. Of course, we have been discussing conservative treatment and surgery, and there is a long range of treatment, surgical treatments, from disc surgery to fusion. But now we are in there with a number of new biological treatments. And my mentor, Alf Nachemson, will maybe be much more critical for the future than he has been in the past. But my best wishes to him. The clinical care, as we see it for the next decade, is having a real potential of some breakthroughs, I think, due to the development of new drug delivery systems. I'll allude to that later, which will be able to combat bad arthritis, degenerated disc disease to some degree, cancer, and also to regenerate some elements of muscular skeletal system. Also, I know that our clinical research will focus more on cost effectiveness of our procedures conducted in randomized controlled trials. Our national registers for orthopedic implant shall improve in quality and in this way give much better results and be of better universal use with high external validity. Focusing on research, we have, as orthopedic surgeons, made big programs on individualized regeneration and reconstruction within the orthopedics. And I think this has been a wonderful opportunity really to go there. It's not something I do in my work room at home. It's a real multidisciplinary approach where we work with natural scientists in all areas. And we have developed platforms all the way, continuously rising our capacity so we can actually match the last speaker, on this. I can give you a newer reference from our center. But you have to work internationally. You have to work multidisciplinary to achieve something here, I think. We have many new tools. We have scaffolds, we have bioactive molecules, we have stem cells, we have nanoparticles. This is a way